Welcome everyone, and thank you for joining us for today's webinar, Perspectives on Oropharyngeal Cancer, Scientific Overview, Clinical Expertise, and Personal Experience. My name is Kathleen Amos, and I work at the Public Health Foundation, and I am joined here today by my colleague, Russ Rubin, for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention. We have three fantastic presenters with us for this webinar and are very much looking forward to sharing their presentations with you. As we get started, we'd like to take just a few minutes to go over a few housekeeping items for this webinar. So on this slide, you should see an image of the attendee control panel, which you should also see on the right side of your computer screen. This control panel is your hub for interacting with the webinar. First, in the control panel, you should see an audio section. You have two options for accessing audio for this webinar: listening through your computer speakers or calling in over the phone. If you are using your computer speakers, please choose the computer audio option. If you are using your phone, please choose the phone call option and enter your audio PIN, which you can find in that audio panel. Please make sure to select the audio option you're using. And if you choose to listen over the phone, please also be sure to mute your computer speakers to reduce any echoing. Regardless of which option you choose, all webinar attendees are muted for the duration of the webinar. The slides for today's presentation are available for download in the handouts section of your control panel if you would like to have a copy. Links included in the slides are not live during the webinar presentation itself, but they are in the handout. So if you download that copy of the slides, those links will take you to any additional resources. Throughout the webinar, please submit your questions or comments for any of the presenters via the questions box in your control panel. Please feel free to send in your questions at any time, and we will address as many as possible during the Q&A session at the end of the webinar. If you have difficulty with any of the technology for the webinar, please also use the questions box to send us a message, and we'll help you troubleshoot. And finally, we wanted to let you know that this webinar is being recorded, and the archive will be available following the webinar to you and to others who are unable to join us today. As you may know, every year over 33,000 men and women are diagnosed with a cancer caused by human papillomavirus, or HPV. While cervical cancer is the most well-known cancer that is caused by HPV, there are 5 other types of cancers that can develop from HPV. Oropharyngeal cancer has recently surpassed cervical cancer as the most common cancer caused by HPV, accounting for nearly 13,000 cases every year in the United States. Compared to HPV and cervical cancer, awareness of the link between HPV and oropharyngeal cancer is still low, which presents an important opportunity for more education. Today, we are pleased to have 2 experts with us to discuss the burden of oropharyngeal cancer, current trends in the epidemiology of oropharyngeal cancer, a clinical picture of the disease, the importance of vaccination to prevent HPV infections, and common questions related to HPV and oropharyngeal cancer. Dr. Amber D'Souza is an associate professor in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. D'Souza's primary research interest is in infectious causes of cancer. Her current research explores the association between HPV and oral, cervical, and anal cancers, global cancer, screening and prevention of cancer, as well as risk behaviors and STDs. Dr. D'Souza also has active research projects in head and neck cancer epidemiology, cancer screening methods, biomarkers of HPV persistence, tobacco cessation, epidemiology of HIV and AIDS malignancy. She is the principal investigator of the Multi-Center AIDS Cohort, or the MAX Data Center. Dr. Carol Fakhri is a head and neck surgical oncologist at Johns Hopkins, an associate professor in the Johns Hopkins Department of Otolaryngology, Head and Neck Surgery, the co-director of the Head and Neck Group in the Bloomberg Kimmel Institute for Cancer Immunotherapy, and the director for the Head and Neck Surgical Oncology Fellowship. Dr. Fakhri's research focuses on the role of HPV in head and neck squamous cell cancer. She has made significant contributions to the knowledge of oral HPV infection and is considered an expert in HPV infection and head and neck cancer. In addition to the clinical implications of HPV in head and neck cancer, Dr. Fakhri is co-principal investigator of a large study to understand screening individuals at high risk of malignancy and evaluating imaging modalities to improve diagnostics and early detection of HPV-related head and neck cancer. Together, they have co-authored several papers about commonly asked questions from patients about HPV-related oropharyngeal cancers, as well as the psychosocial experiences of HPV-related oropharyngeal cancer survivors, both during and after treatment. In addition, we are joined by Jason Mendelson, an HPV oropharyngeal cancer survivor, who shares the story of his illness and recovery as a means to educate the public about HPV and its link to oropharyngeal cancer. Mr. Mendelson is co-founder and president of Ashar Group, LLC, a privately held nationally licensed firm specializing in the secondary market for life insurance. He is also a stage 4 HPV-related oral cancer survivor and serves as the co-chair for the Patient Education Committee for the Head and Neck Cancer Alliance. He made the decision to share his cancer story publicly so that others could learn about HPV-related oral cancer screenings, and the HPV vaccine. His website, www.supermanhpv.com, offers valuable information about oral cancer awareness with the hopes to help eliminate HPV-related oral cancer for future generations. Mr. Mendelson serves on the board of the Florida Hospital Cancer Institute and the Jewish Pavilion of Central Florida. He and his wife, Ronnie, have been married for 22 years and have 3 children, 17-year-old son and daughter, who are twins, and an 11-year-old son. Mr. Mendelson will share his story today, discussing the process of diagnosis, treatment, and recovery from oropharyngeal cancer. Well, I'm pleased to turn the floor over to Dr. D'Souza to get us started.
Good afternoon, everyone. I'm happy to be with you today. Take control of the screen. There we go. So the objectives of today, I'm going to begin by talking about the burden and epidemiology of oropharyngeal cancer, and then talk about how common oral HPV infection is and its natural history. Dr. Fakhri will talk about differences between oral cancers and oropharyngeal cancers and common questions and answers about this topic, and then we'll talk with Mr. Mendelson from a survivor's perspective. So to begin with the epidemiology of oropharyngeal cancer, and I'll be focusing today on sharing data from the United States. When we talk about oropharyngeal cancer, we're talking about cancers that are at the back of the throat and base of the tongue. So these are cancers in the tonsil, base of the tongue, pharyngeal wall, uvula, and soft palate. Thinking about all the types of cancers that are caused by HPV in the United States, oropharyngeal cancer is the most common HPV-related cancer in men, but in women, cervical cancer is the most common HPV-related cancer. Oropharyngeal cancer is actually much more common in men than women, and if you look at this picture that's shown here, you can see that there's over 14,000 cases of oropharyngeal cancer in men in the U.S. every year, compared to only a little over 3,000 cases of oropharyngeal cancer in women each year. Taken together, there's over 18,000 oropharyngeal cancers in the U.S. each year, which is much more common than cervical cancer in the U.S., and that is a recent trend. That is in the context that most cervical cancers are prevented by effective screening. So without screening, cervical cancer would be the much more common cancer, the most common HPV-related cancer, as it is in many other countries outside of the U.S. But in the U.S., because we have such effective cervical cancer prevention efforts, the number of oropharyngeal cancers now each year is significantly higher than the number of cervical cancers that we see in the U.S. When we talk about the incidence of oropharyngeal cancer, this is using SEER data, so looking at the trends over the past 20 years in the United States, you can see in the blue line the risk for oropharyngeal cancer among men, and in the black line, the risk of oropharyngeal cancer among women. So the first thing to note is how much higher risk for oropharyngeal cancer is among men than women. The second thing to look at is how there's been this increase in incidence that's been quite steady, a 2 to 3% increase every year for almost 20 years now among men. And we don't see that same type of increase for oropharyngeal cancer risk among women. When we contrast this with the other type of head and neck cancers, so not the cancers in the oropharynx, but in the other parts of the head and neck, and these are cancers that are caused by primarily tobacco and alcohol use, we see the rate of those cancers has consistently decreased in men and in women, and that's primarily due to decreases in tobacco use in the U.S. So if we look at the rate of oropharyngeal cancer, by age group. What we can really see here is that increase that's happening in oropharyngeal cancer risk among men is happening across men of many different ages. So you can see here for men in their 50s in the red line, for men in their 60s, which is this green line, and for men in their 70s, which is the blue line, the risk for oropharyngeal cancer has, increased substantially over the past 20 years. The cancer is much rarer among young individuals in their 40s, so we do have oropharyngeal cancer occurring there, but the increases that you see in the magnitude of that cancer is not as high. And the increase in the risk of oropharyngeal cancer is also not as high among individuals who are over 80, where there's lots of competing risks. But we are seeing it for men between 50 to 79. If you look at oropharyngeal cancer among women, we don't see the same kind of increases in the U.S. that we're seeing among men. In fact, we see some decreases in oropharyngeal cancer among women that are believed to be explained by decreases in tobacco use, which is another cause of oropharyngeal cancer. But we don't see the same type of increasing incidence. All right, and I wanted to show one slide about the racial disparities in oropharyngeal cancer. So if we, before HPV was the primary cause of oropharyngeal cancer, thinking back in the early 90s, the rate of oropharyngeal cancer was considerably higher among Black men than men of other races in the US. That's when smoking and tobacco use was the main cause of oropharyngeal cancer. As the epidemiology of this disease has changed, what we've seen is a decrease in incidence of oropharyngeal cancer among Black men, right, as tobacco use has decreased. But we've seen an increase in HPV-related oropharyngeal cancer, and that change has occurred more among white men than among Black men, and this has led to an increased incidence where the incidence of oropharyngeal cancer among white men, seen in this blue line, is now higher than the incidence of oropharyngeal cancer among Black men. I will also note in this slide that you can see the increase in oropharyngeal cancer is not just among white men. We've seen similar increases among Hispanic men, and there's a little bit of a suggestion of an increase among Asian men as well in the United States. In other data not shown here, there is evidence that the risk for HPV-related oropharyngeal cancer is also increasing among Black men. But because there's a higher tobacco use history among Blacks in the U.S., the decrease of tobacco-related oropharyngeal cancers is hiding that small increase in HPV-related oropharyngeal cancers among the Black men, leading to an overall decrease in the rate of oropharyngeal cancer among Black men. But it is not that Black men are not at risk for oropharyngeal cancer or for HPV-related oropharyngeal cancer. They just have a lower incidence of HPV-related oropharyngeal cancer than white men due to differences in sexual behavior. Once you control for differences in oral sexual behavior, it explains the racial disparities that we see in oropharyngeal cancers. Okay, I wanted to share some data showing how the epidemiology of oropharyngeal cancer has changed in the United States. In both of these studies, what you see is over time, the percent of oropharyngeal cancers that were HPV related when they tested the tumors for HPV DNA. And you can see that in the 80s, less than a quarter of oropharyngeal cancers were HPV related. In the 90s, that increased to half of oropharyngeal cancers. And now in the 2000s and in more recent studies, we see the majority, over 75% in the most recent studies, of oropharyngeal cancers in the US are caused by HPV. So this has been a dramatic change, and it's explained both by a decrease in tobacco-associated oropharyngeal cancer and by an increase in the rate of HPV-related oropharyngeal cancers during this time period. Okay, I now want to turn and talk a little bit about oral HPV infection itself and the natural history of these infections. So to talk about oral HPV natural history, we need to measure those infections. When you have someone who already has an oropharyngeal cancer, you can measure HPV in the tumor, which is the gold standard of knowing that HPV is there and biologically active. But in healthy individuals who do not have cancer diagnosed, measuring oral HPV infection is much more difficult. We can look for HPV antibodies in their blood, but if an HPV antibody is detected, it could represent an HPV infection that's oral, but it could also represent an HPV infection that is genital or anal. So it's not site-specific. When we think about swabbing the mouth, if someone has a lesion or a cancer and you swab and test for HPV, the detection is pretty good. But in people who don't have any visible lesions, you don't know where to swab, and you can try to rub different parts on the tonsil, but HPV detection in research studies has not been very good using that method. So the best available way that we have to study oral HPV infection is to give someone some saline or mouthwash and have them do a rinse and gargle where they're swishing the mouthwash around and it's collecting exfoliated cells from throughout their throat and mouth that you then test for HPV DNA. And this is not a perfect test. It doesn't appear to always measure HPV infection that may be hidden in the tonsillar crypts. So we think that it misses some infections, but it is pretty reliable when measured in the same person on multiple days, back to back, and it is the best test that we have, although we know it is not perfect. So the results that I'm going to share today are all done using all these oral rinse and gargle samples. And when you do that and look at how common is it to detect oral HPV DNA in the general population, well, there's many different kinds of HPV-16, many different kinds of HPV, only some of which can cause cancer. And on this slide are those oncogenic HPV types, or the types of HPV that we know can cause cancer. But almost all of the HPV-related oropharyngeal cancers are caused by a single type, HPV-16. It causes more than 90% of the HPV-related oropharyngeal cancers. So that's the most important type. And HPV-16 is detected in only around 1% of the general population at any one time point. So if you take a group of people and you look, around 1% of them will have a prevalent oral HPV-16 infection. And HPV-16 is actually the most common type detected orally. These other oncogenic types are all detected in less than 1% of the general population. When we look at how common it is to have an oral HPV infection, and here we look at any kind of HPV, not just HPV-16, we see that the more lifetime oral sexual partners you've had, the more likely it is that you have an oral HPV infection. So even people who say they've never performed oral sex in their life, some of them do have an oral HPV infection. But if you look at people who say they've had 2 to 5 sexual partners, well, they're twice as likely to have an oral HPV infection detected. And if you look at people who say they've had more than 20 lifetime oral sexual partners, well, you know, they're more than 5-fold more likely to have an oral HPV infection detected. Now, with most sexually transmitted diseases, we expect to see that the peak prevalence is in the 20s, where people have their most sexual partners, and then the prevalence decreases with age. With oral HPV infection, that's not really what we see. So if we look in men who are in their 20s, 30s, 40s, 50s, 60s, the prevalence of oral HPV infection is somewhat common, which is surprising. But no matter what age you look at, the likelihood of having an oral HPV infection detected, and here we're looking at any kind of HPV DNA, even the kinds that aren't oncogenic and can't cause cancer, it's always more common to detect oral HPV infection in men than in women. But most of that is not, again, HPV-16. If you look at how common it is to detect HPV-16, it's only in 1 to 2% of men. And in women, it's less than 1% of women. It's really 0.5% or less of women that have an HPV-16 infection detected at any one time point. So why are men more likely to have an oral HPV infection than women? Well, there are some differences in sexual behavior, but those differences in behavior do not completely explain the differences that we see in oral HPV prevalence. And I'm going to share some data with you in a few slides that talks about that. Looking at all the risk factors that we know about, Dr. Fakhri and I created this infographic last year to try to help people understand what is their risk for oral HPV infection, and this would be for the general population. And so the first differentiator is really sex, whether you're a woman or a man, and then after that, number of oral sexual partners. So women who have only had 0 or 1 oral sexual partner have very, very low prevalence of oral HPV-16 infection and any oncogenic infection. And even the women who have few more oral sexual partners, their overall HPV prevalence at any one time point remains very modest. So oral HPV infection among women is low. Among men, we see increasing oral HPV prevalence with number of lifetime oral sexual partners, and we see further differentiation by whether they currently smoke. So current smoking is associated with an increased prevalence, whether that's because tobacco-related inflammation makes those infections more likely to become established when someone's exposed, or perhaps makes them less likely to be cleared once you're infected. We do see the association with current smoking. And so someone who has 2 to 4 lifetime oral sexual partners and smokes has a higher oral HPV prevalence than someone who has the same number of partners but doesn't smoke. And the highest risk group that we saw was men who have 5 or more lifetime oral sexual partners and smoked, but even in this group, only 4% have a current HPV-16 infection, and 15% had a current infection with some kind of oncogenic oral HPV infection. So that talks about how common oral HPV infection is, but what about incidence or risk of infection? Well, several cohort studies have looked at this. In studies of general population adult men in the first line or college-age men in the second line, we saw that around 7% of the adults and 12% of the college men acquired a new oral HPV infection in 1 year. So this isn't HPV-16, it's just any oral HPV infection, but it gives you a sense of exposure. If you look at a higher risk population of young adults who are in an STD clinic for STD symptoms, so they're already having multiple partners or being exposed to an STD, we see 1/4 of the men and 16% of the women acquired a new oral HPV infection within a year after their STD clinic visit. And so what this suggests is that many people are likely exposed to oral HPV infection in their lifetime if we see this level of exposure within 1 year. But this doesn't mean that everyone is exposed to oral HPV-16. So if we look at HPV-16 specifically, you can see that only 1% of the men, 3% if you look at the younger men in the STD clinic, right, are exposed within 1 year. So one of the questions we're often asked is, well, what are the chances in someone's lifetime of being exposed to oral HPV-16? And while we don't know exactly if around 1% of general population men and a higher proportion, around 3% of people in a higher risk category, right, are exposed within 1 year, well, it suggests within the lifetime that less than half of men would be exposed to oral HPV-16. It's not ubiquitous the way genital HPV infection is, but it does suggest that it's somewhat common to be exposed to HPV-16 in one's lifetime. It might be 10, 20, 30% of men might by chance be exposed to type 16 in their mouth. But among women, it suggests that that lifetime risk would be lower, because even the most highly exposed women here, only 1% were exposed to oral HPV-16 or acquired oral HPV-16 in a year. And so thinking about these risk factors, how do people acquire oral HPV infection, and why is it different in men and women? Well, when we looked in that STD clinic population, we followed those young adults every 3 months, looking at what their behaviors were and whether they acquired a new oral HPV infection. And we saw that if you had recently performed oral sex in the past 3 months, you were 3-fold more likely to acquire a new oral HPV infection. And the more partners you had, the more likely you were to acquire a new infection, exactly what we would expect for a sexually transmitted infection. However, when we looked among the women in the study, we did not see the association between how many recent oral sex partners you had and risk of acquiring an oral HPV infection. So we wondered if perhaps it's not the number of partners you have, but who you are performing oral sex on. Perhaps the HPV viral load in the vaginal fluid is much higher than on the penile shaft, and performing oral sex on a woman might confer a higher risk of infection than performing oral sex on a man. We did happen to have individuals who were gay in our study, and we looked at the men performing oral sex on a woman. They did have an increased risk of acquiring oral HPV infection, but for our gay men, performing oral sex on a man in the past 3 months was not associated with an increased risk of oral HPV infection. So that supports the hypothesis that performing oral sex on a woman might confer higher risk of oral HPV acquisition than performing oral sex on a man. However, when we looked in our women who were heterosexual and performing oral sex on a man did not have an increased risk of oral HPV incidence, but our lesbian women who were performing oral sex on another woman, we thought would have an increased risk of oral HPV acquisition, and they also did not. So this suggests that it might not just be who you're performing oral sex on, that there might also be an innate immune difference in men and women. For example, there is some suggestion that when men and women are exposed to genital HPV infection, women might mount a more robust immune response to that cervical HPV infection than men mount to their penile HPV infection. And when the women are later exposed to oral HPV infection, they might be less likely to acquire that infection they're exposed to because they might already have immunity from their previous genital HPV infection, while some men might not. It's not clear whether that is the case, but those are some of the hypotheses that might explain why we see these differences in men and women who have the same behaviors. When we think about what happens once you do have an infection, because we do see both men and women who do acquire oral HPV infection, although men have a higher risk of acquiring it, both men and women who acquire an oral HPV infection usually clear that infection on their own with no treatment and no symptoms within a year. They usually don't know they're infected and they just clear it on their own. That's the same as we know for cervical HPV infection. And I've put up a little curve here from a different cervical HPV study that happened to be comparing HIV positive and HIV negative women. But it's the same idea, just to show you that most people who have a cervical HPV infection clear it quickly within a year or two. They clear that cervical HPV infection. And we see the same thing for oral HPV infection, that most people who become exposed clear it on their own within a year or two. So why is the risk of HPV-related oropharyngeal cancer, as well as oral HPV infection, so different among men and women? Well, we did some research in NHANES, which is a population-based national study, and we saw that men and women had the same likelihood, same history. Most men and most women in the U.S. have performed oral sex in their life. And it's true that there are more men than women who had a high number of partners, so 5 or more lifetime oral sexual partners. But the level of that difference in having a high number of partners is small compared to the difference that we see in the level of oral HPV-16 infection and the level that we see in actual cancer incidence. So there's a 5- to 6-fold difference in infection and cancer, while there's a less than 2-fold difference in behavior. So the number of people you have oral sex with does not completely explain the differences we see among men and women in oral HPV-16 infection and cancer risk. Another study in NHANES showing that same data in a slightly different way has the same conclusion, that if you look at men and women with the same number of partners, say 5 lifetime partners here, the risk of having an oral HPV infection, here shown through prevalence, is higher in men than women. Regardless of the number of partners, comparing men and women with the same number of partners, the per partner risk of acquiring an oral HPV infection appears to be higher in men than in women. So we did a research study where we compared an oral HPV prevalence with lifetime cancer risk to see what happens once you are infected. And what we show here is that while around 6% of men in the general population have some kind of oncogenic oral HPV infection, less than 1% of men in the general population will go on to develop oropharyngeal cancer. And this supports the natural history that we showed that most people who acquire an oral HPV infection will clear that infection on their own. And we see the same thing with women, that infection is less common than in men and cancer is less common than in men. But the same relationship holds that most people who acquire an infection will never in their lifetime go on to develop the cancer. If we look not in your lifetime, but just in the next 20 years, and we subdivide it by age, you can see how rare this cancer is. So while I showed you that the incidence of oropharyngeal cancer has increased rather dramatically over the past 20 years among men, and it is now more common than cervical cancer is in the United States, it is still a rare cancer overall in the general population. And you can see, regardless of age group, for men or for women, the risk of developing oropharyngeal cancer in the next 20 years remains very low. So in summary, oral HPV incidence is much lower than what we see for genital HPV incidence. Of those people who acquire an infection, most people clear it within 1 to 2 years, but not everyone. We do see a group of people who have persistent oncogenic oral HPV infection. Men have a higher rate of acquiring oral HPV than women and are also less likely to clear an HPV infection once acquired. And these differences are not fully explained by the number of lifetime oral sexual partners. Oral HPV-16 prevalence is low in the general population, and most people who become infected will not go on to develop oropharyngeal cancer. I'm now going to pass it over to Dr. Fakhri.
Hi. So now I'm going to talk about the differences between oral cancers and oropharyngeal cancers. The terms are used interchangeably at times, and people will say oral cancer when they mean oropharyngeal cancers, and the two are very different and not overlapping entities. When we talk about HPV, we're referring to oropharyngeal cancers and a subset of oropharyngeal cancers. About 80% of oropharynx cancers in the United States are HPV related. In contrast, very few oral cancers, cancers of the tongue and the front part of the mouth, are due to HPV. So when we refer to oral cancers, we're referring to the front part of the mouth, and it ends at the back of the tongue. And so everything in front of it, including the roof of the mouth, teeth, up to the lips and the tongue, is referred to as an oral cancer. Oropharynx cancers are cancers of the back of the mouth, and as the back of the mouth goes down to meet the voice box. And so the oropharynx, if you look in sagittal or side view through a person, really denotes the way back of the mouth and going down along the air column to the start of the voice box. The sites of the oropharynx are the uvula, which is the little tissue that hangs in the back of the mouth, the tonsil tissue, which many people have removed in their youth, and the base of the tongue, which is the very back of the tongue as it goes down into the throat, so the part that you can't see anymore through the mouth. The soft palate is also considered to be part of the oropharynx. But when we think about HPV-related oropharynx cancers, they primarily affect the tonsil and the base of the tongue. And that's because on the base of the tongue, there's also tonsil tissue. So that's what unites the two sites. HPV-related cancers really don't affect the rest of the oropharynx. They don't affect the uvula or the soft palate. So next I'm going to discuss how to address some common questions that we get about oropharyngeal cancer and the vaccine. So healthy individuals who don't have cancer often will ask, well, what's my risk of developing oropharyngeal cancer? As Dr. D'Souza just outlined, the risk of oropharynx cancer in the general population is very low. It remains a rare cancer in the United States and abroad. while the risk is higher among men than women, it's still a rare cancer. Most individuals will have been exposed to HPV orally at some point in their lives. However, very few people will end up with an oral HPV infection. As Dr. D'Souza just reviewed, risk of oral HPV infection increases per increase in number of oral sex partners. And even though someone may have an infection, in all likelihood, they will clear that infection within 2 years, and it happens naturally as their immune system helps get rid of the infection. What are some of the risks of HPV-positive oropharynx cancer due to? Why is it that men may be at increased risk than women, and why have we seen increases in incidence over time? And these are really questions that we can't answer at this point. We have hypothesized that there have been changes in the in sexual behavior over time with the sexual revolution, increased number of sexual partners, earlier sexual debut. We don't quite know the answer to that question yet. Why are men at increased risk for cancer than women? As Dr. D'Souza mentioned earlier, there's a thought that men have a lower immunity and are unable to clear the infection as compared to women. But again, we don't have very good evidence for that at this point. The good news is that we have evidence to suggest that HPV vaccine may prevent future rises in incidence of HPV-related cancers. And therefore, that gives us optimism. So among patients who have, individuals who don't have cancer, but they are worried about their future development or risk of either HPV infection or HPV-related cancer, they often ask us whether or not they can get tested for the infection. And the simple answer is no. While there are tests available on the market, there is no FDA-approved test to detect oral HPV DNA. And so if we were to get a test that someone has an HPV infection or that it's an oncogenic HPV infection, we don't know if that result would be reproducible in another laboratory. And so we really don't recommend that individuals be tested for oral HPV infection outside of a clinical trial or study. If there were a test available and HPV were to be detected, at this time we have no treatment recommendations, screening recommendations, and again, most people will clear that infection on their own. So providers should not be offering HPV testing to their patients using any saliva kits. While our natural history data is limited, based on what the data that Dr. D'Souza outlined earlier, having an oral HPV infection at one time point is not a good predictor of future risk, and most people will clear that infection within 2 years. Therefore, testing someone at one time could actually provide more harm than benefit. We don't have any way of screening these individuals, and we have no way of treating that infection or the presumed infection. And in addition, I think we have to think about the benefit versus harm of testing someone for this infection. There might be psychological harm of thinking that someone's at increased risk for a future cancer, although we have no way of quantifying what that precise risk is. Some people may go on to seek an intervention and find a provider to do that intervention. And every intervention that we as providers give has downsides. And so it's important to consider the potential harm and the lack of benefit when testing someone for oral HPV DNA. So because of all these lines of evidence and considerations, the American Dental Association, along with the American Head and Neck Society, do not recommending any salivary adjuncts to test for oral HPV DNA. Just want to make sure my slides. So the good news is that we have the vaccine. The HPV vaccine has been shown in large prospective randomized studies to prevent anogenital HPV infection, precancers, cancers, and genital warts. Unfortunately, we don't have similar data for oral HPV infection or oropharynx cancer. In the limited data we have, it suggests that the vaccine will have high efficacy for prevention of oral HPV infections and future cancer, although those were not defined outcomes that were investigated in any of the trials. So in a study among women, which again is not the relevant population for oropharynx cancer or even oral HPV infection, at one time point when investigators looked to see whether or not women who had been vaccinated versus controls had presence of infection, 15 women in the control group had infection as compared to only 1 in the vaccination group, which suggests that the vaccine will have high efficacy in the order of 90% to prevent oral HPV infection. Dr. Souza referred to the NHANES study, which is a nationally representative study in the United States and reflects a general population. And again, we don't have any prospective data for the vaccine and oral HPV infection, but in a cross-sectional study, when investigators asked individuals whether or not they had been vaccinated, we see that there was a significant reduction in oral HPV infection among those who had been vaccinated. Unfortunately, many people are not vaccinated in the United States, and so what we see is that there's a high number of preventable infection, and very few of the infections were actually prevented using the vaccine. So with higher compliance, we hope for improved prevention of oral HPV infection. So in summary, it's very important for physicians to be comfortable talking about HPV, as that puts patients and healthy individuals at ease to talk about HPV and talk about potential risk and vaccination. When patients are worried about their risk of oral HPV infection with very common sexual behaviors, the important message is to reiterate is that oral sex is common, infection is somewhat common or rare, and that cancer is even more rare. And so it should be an afterthought for individuals, and they should not change their sexual behaviors because of the potential worry of either infection or cancer. At this point, we don't have any effective screening, and we don't recommend any testing outside of clinical trials, but given the vaccine, we have optimism about the prevention. And with that, I'll turn it over to Mr. Mendelson.
Good afternoon. Before I begin, I'd like to thank CDC for inviting me to share my story today. You'll soon understand that I'm not a doctor. I am a survivor, because my presentation over the next 12 to 13 minutes will be certainly less technical. I hope you find it to be interesting and informative, and that it provides you with the information you need to continue doing what you're doing to protect future generations. I hope this encourages, my story helps you to encourage parents, families, and others to learn more about the HPV vaccine, and that parents will understand that the HPV vaccine is a vaccine that will protect both their sons and their daughters, not just their daughters, from getting a cancer that is preventable. What you do is extremely important. I commend you for protecting families. I also want you to know that while I launched my site, Superman HPV, I don't have a Superman complex. I adopted the name because my friends called me Superman during chemo and radiation, stating that I was strong like Superman. Thought the name was catchy and that it would draw attention to my diagnosis so people would learn more about HPV oropharyngeal cancer. Again, as an HPV cancer survivor, I wish the HPV vaccine would have existed when I was a young boy, so I wouldn't have been diagnosed with HPV tonsil cancer at age 44. On a side note, hopefully you think this is interesting. Normally I present to people so I can see when they're smiling or laughing, but I oftentimes get asked if my diagnosis is what Michael Douglas had, and I always tell them it's the one thing that he and I have in common outside of our love for Catherine Zeta-Jones. Before I share a brief video with you, I'd like to tell you a little bit about my family. I often describe us as a blend between the Waltons from TV, so hopefully many of you on the webinar today know the Waltons, John Boy from years ago, and My Big Fat Greek Wedding, and then you sprinkle Judaism on top, and that's us. And I think that's important for you to understand because I had a large support system. We have a family business, like they mentioned earlier, and my brother and his wife and kids are our next door neighbors. As well as they mentioned, I've been married 22 years to my wife, Ronnie. She's awesome. She was a rock during the entire cancer process. And I have boy-girl twins we do that are 17, seniors in high school, and an 11-year-old son who's in 6th, and my mom and dad and sisters live just 5 minutes away. I put together a brief video so you can feel a little more connected to my story. I will likely get choked up, as I'm a guy that tears up during Hallmark commercials. I'll make a few comments during the video. On a side note, the music that you will hopefully be able to hear is a song that my mom recommended to me while I was going through radiation treatment. And so if you would go ahead and play the video, you'll be able to learn a little bit more about me and my journey, and there are subtitles that you can read. So please go ahead and play that. Thank you.
Thank you, Jason. Everyone should see the video pop up on their screens momentarily. Just be aware that everybody's internet connections have different speeds, so we'll have Jason continue with his story as soon as most of you have seen the video. Enjoy. Turn up your computer speakers to hear the sound. Jason, thank you very much for that great video. And when you're ready, back to you.
Thank you. Yes, I mean, I have to tell you, so I share that video, I get choked up whenever I share it, and I show it because if you think of all the events I would have missed had things not have gone well, and you have the ability through education and really talking to parents about the HPV vaccine to make sure parents are there for their kids and kids are there generations to come. So it's, anyway, it gets me choked up. Let me tell you about life before cancer very quickly. I was working 50 to 70 hours a week, traveling 2 to 3 times a month all over the country. Like I told you, like they said earlier, we have a family business. I was at all my kids' activities, travel, sports, date night with my wife. Life was awesome and hectic all at the same time. April 17th, 2014 changed everything. That was a day that I was taking a financial exam for our industry, getting my securities license. I put my hand on my face to ponder a question and onto my neck and felt a small bump. I said to myself, I remember clearly at the time, I don't have time to think about dying. And I said it because I shave every day, never felt the bump before, but I went home, showed my father, who's a physician, the bump. He said, let's call the ENT. I called the ENT. He said, you don't smoke, you don't drink, come see me in a few weeks. I am a guy that goes to the doctor. So that was a Thursday. Monday, I showed up at the doctor. They put me on 10 days of antibiotics and steroids. They told me in the event that the bump didn't go away, that we would immediately schedule a needle biopsy and CAT scan. I quite honestly thought nothing of it. I was at my ideal weight. I was exercising. I was feeling awesome. No symptoms. I went to the Keys on vacation with many of my friends. Ran the equivalent of a 5K. Flew from the Keys to DC, where I lobbied on Capitol Hill. Life was awesome. I returned on a Wednesday. Thursday had a CAT scan. Friday had a needle biopsy, and on Monday found out that I had stage 4 at the time, HPV tonsil cancer. Today, with some of the downgrading and staging, it would have been stage 1, but at the time, stage 4. And I was devastated. Never thought I would be getting cancer or being diagnosed. Talked to my family on the way home, called my 2 insurance agents, life insurance agents, and said, please don't let my policies lapse. I need to make sure they're on automatic draft. I called my friend, a radiation oncologist, and said, it looks like I'm going to become your patient. And honestly, at the time, I knew HPV was related to cervical cancer, had no idea it was related to oral cancer or oropharyngeal cancer. And at the time, I did not know that 3 out of 4 adults by 30 have HPV, 62% of freshmen in college, that men between 40 and 60 are the most highly diagnosed. And at the time, they said you likely got exposed to the virus decades ago, over 30 years ago when I was in college. And I ended up having a radical tonsillectomy, neck dissection, so 42 lymph nodes removed, followed by 7 weeks of chemo, radiation, and a feeding tube. At that time, I even made videos to my kids saying goodbye. They went something like this: one day you're going to get married. I'm not going to be there. This is what's important. And quite honestly, the reason I went public with my story and I share it as often and as proudly as I can is because I want to stop other parents from ever having to make such videos to their kids from a cancer that's preventable. Treatment didn't seem difficult at first. I ended up, in week 5, I ended up with 3rd-degree burns in my throat. I had chemo every Thursday. The whole process from, testing to chemo to, flushing the kidneys took around 7 hours. That was every Thursday. I had radiation 5 days a week. In the morning, 15 minutes for 7 weeks. Around 5 weeks, I couldn't swallow my own saliva. I would spit into a large cup every day because I couldn't swallow. Again, it felt like someone had cracked a glass bottle and shoved the glass in my throat. And again, radiation, which most of you likely know, is when you have your head clipped down to a table and you sit there and just wait until it's over. Not painful, just time consuming. I would go to sleep at night. I would wake up gagging within 15 minutes because the saliva had covered my breathing way. And I'd be checking my blood pressure 20 times a day in my pulse to see how I was doing. I literally would become fully dehydrated, and I had a feeding tube, and I wasn't sweating, not having diarrhea, not throwing up. So the burns from the inside of my throat were sucking the fluid from the inside out. It was honestly exhausting. I tried to find some humor in it. I was in bed around 18 hours a day for a month, and the only thing that afforded me to do was watch 7 years of Lost in 2.5 weeks. The only joy I could find in that. The last day of treatment for me was August 11th, 2014. I thought it would be the best day ever. I rang the bell, my hands, I was just thrilled. Then I came to realize that radiation is the gift that keeps on giving. the effects are cumulative, and the next 3 to 4 weeks were the worst and the most brutal of the treatment, with everything else I already mentioned. It took me somewhere between 4 to 8 months to feel significantly better and stronger. Today, I'm cancer-free. I have 85% of my saliva back. I still get Charlie horses in my neck a few times a month. I use Prevident gel trays to keep my teeth strong due to lack of saliva. I use them now 3 to 4 days a week. I used to use them 7 days a week for 3 years. I use Floridex toothpaste to keep my teeth strong. I gargle every morning with hot water just to loosen up some of the phlegm. And I exercise, I will tell you, as often as I can to serve as a role model for other cancer survivors, that they too can embrace their new normal and enjoy life. I'm addicted to my Peloton bike, and that's pretty much what I do 45 days a week. While today I'm cancer-free, I'm really working to give back, and I want to mention this, that I'm on the executive board for the Head and Neck Cancer Alliance. We're forming a survivor patient caregiver network, and so through a website I launched, supermanhpv.com, I get contacted probably 3 to 5 times a week by people all over this country and worldwide that tell me when they see my website, they no longer feel alone. Because when I initially got diagnosed, I went to the web and everything on the web was about people who had head and neck cancer from smoking and drinking, almost nothing from HPV or pharyngeal cancer. So I launched that website. NBC wrote a news story. 500,000 people read it overnight. We ended up on NBC Nightly News with Lester Holt a year ago. And again, I tell you all this, so if you have patients that are diagnosed and need someone to speak to, my cell phone's out there, my email's out there, which is listed obviously on this slide. I'm active with the American Cancer's HPV Roundtable. And again, I'm sharing my story so other parents don't have to make videos to their kids. Last thing, I also created an Amazon Alexa skill. Again, I don't sell anything, but I tell you all this, so if my information can help any of your patients, but that Alexa skill is about surviving throat cancer. I hope what I've shared today helps you relate better to your patients or parents or family members or children, anyone, about how you can maybe share a little bit more about why the HPV vaccine is important, why people should speak to their kids' pediatricians and their family practice doctors about that. My goal is to have my story shared in as many languages as possible in all 7 continents to save lives worldwide. And I hope what I've shared has touched you in such a way. Please reach out to me if I can be of any help for you or for your practice or the families and patients you serve. And again, thank you for doing the work you do, because you're protecting families like mine from a cancer that's preventable. Have a wonderful day.
Thank you, Jason. That was fantastic. And thank you to Dr. D'Souza and Dr. Fakhri as well. I know we are running close to time. We're going to have just a bit of time for Q&A here. We're going to try to share 1 or 2 of the most frequently asked questions that we've been seeing come in through the chat box. We have so many questions coming in. Please do continue to send those questions in through the questions box. We will follow up with written answers to them following the webinar. So one of the questions we've been seeing the most frequently, can the vaccination be given at any age? When can we expect to start seeing more emphasis on vaccinating adults, say in the age 45 and up age group? So I don't know, Dr. D'Souza or Dr. Fakhri, if you have any thoughts on that question?
Sure. Hi, everyone. So the HPV vaccine is approved for use in boys and girls 9 and older. So the targeted ages are 11 to 12. We have catch-up vaccination going older than that. There's been recently this year a review of vaccination among, I don't know if middle age is the right word, but above the previous. Previously, it was recommended up to age 21 in boys and 26 in girls. That was based on cost-effectiveness literature, because once you've been exposed to HPV, the vaccine does not protect you, and most people have had enough sexual partners that after ages, in their 20s, they're less likely to get benefit. But additional research was done, and it showed that while the current HPV vaccine protects against 9 different types of oncogenic HPV, many people have been exposed to some of those types, but not all, so they still continue to get benefit by protecting you from the types they haven't been exposed to. So the recommended ages was now extended. The FDA has approved the HPV vaccine for use up to age 45, but that doesn't mean that it is paid for by insurance and readily available to everyone in those older ages to get vaccinated. So it is FDA approved. The vaccine can be given at those older ages, but it will depend on the state and availability and provider in terms of how people access that. The primary push for vaccination should continue to be vaccination of young individuals, up through their 20s. But for older individuals, there is a more modest benefit. But if they're going to continue to have many sexual new partners, the evidence suggests that there is still some benefit.
Great, thank you so much. We also have a number of questions, and I'm going to sort of lump them all together, related to risk factors. So questions like, does having your tonsil removed affect your infection risk? Is smoking relevant for women in terms of infection risk? And does alcohol play a role in infection risk? If you have any thoughts on any of those, I think that would be helpful.
So in terms of risk factors, we've talked about the sexual behaviors being risk factors for oral HPV infection. There is some data to suggest that having your tonsils removed reduces the risk of cancer and reduces oral HPV infection. But I say that with great caution, because that does not mean that people should be having tonsillectomies for this purpose. And there is a mortality risk, meaning people die from tonsillectomies and life-threatening bleeding. And so the risks do not outweigh the benefits for this reason. In terms of tobacco use, there is a strong suggestion that tobacco use increases the risk of oral HPV infection. And it looks like in a dose-response fashion with increased tobacco use, there's more, the risk of infection or the odds of having an infection increases. We don't see that necessarily with alcohol, but alcohol and marijuana are both probably maybe confounders and may increase risk or increase sexual behaviors, which are surrogates for exposure to oral HPV infection.
Wonderful. Thank you so much. We do have many, many more questions. Apologies for not being able to answer them all on the webinar today. We will follow up with written answers to the questions, so please do continue to send them in. We'll leave the webinar system open for several more minutes.
We can continue to answer if you'd like. We're both here.
Sure. We can do a few more. So we have questions about who provides the oral rinse gargle testing. Is that medical or dental? Is there sort of information that we can give to dental care providers, or that you might offer dental care providers in terms of HPV and oropharyngeal cancer?
So as we said earlier, we don't think that anyone should be providing them. They are provided by dental providers out there, but it is not an FDA-approved test, and it has not been validated in recognized labs. So we don't know whether or not it's telling us the truth, essentially. So even if a test is positive, we don't know if that's true. And if a test is negative, we don't know if it's true. And we don't know what to do with that information. So we don't recommend people seeking these tests.
Great. Is there a geographic distribution or pattern for HPV?
No, for oral HPV infection, we really see the prevalence being driven by gender and by behavior. So variations in oral HPV prevalence, once you account for differences in number of oral sexual partners, we don't see there being other geographic differences once those behavioral differences are accounted for within the U.S. There have been differences noted between countries, but often the behavioral data is not there in those other countries, so we don't know whether or not differences, lower rates of HPV-related oropharyngeal cancer and oral HPV infection in some studies outside the U.S. is entirely explained by differences in sexual behavior or if there's other factors.
Great. We have several questions related to sort of the time lag, if you will, between the infection with HPV and delayed development of cancer. So is it possible to be infected with HPV and then develop cancer sort of several years down the road? What does that look like?
So we can't give the exact timing from infection to development of cancer, but what we know is that it is many, many years, and this is for HPV and all the cancers that it causes. So we know that for HPV infection to lead to cervical cancer or anal cancer is over 10 years, maybe 20 years or longer. All of the data we have for oral HPV infection and oropharyngeal cancer suggests that same long time span, and there have been studies that have looked back 10 and 20 years and seen that people who went on to develop cancer had the biomarkers for those infections 10 and 20 years beforehand, even though they were apparently healthy at that time point. So although we don't know the exact number of years, we would be very surprised if an individual who's not immunosuppressed or very ill for other reasons, we certainly think the time span is more than 10 years.
Fantastic. Thank you so much for being willing to stay and answer a few more questions. I know we only have the system live for a few more minutes, so I want to make sure that we wrap everything up here and let everyone know where they can access the resources from the webinar today. Again, please continue to type your questions in. Jason, we have so many comments of people thanking you immensely for sharing your story and sharing their own stories as well. So we really appreciate that contribution to the webinar today. We would like to thank everyone on the line here once again for joining us for this very informative webinar. We hope you enjoyed it. We certainly did. As mentioned at the beginning, we have recorded the webinar today. The archive will be available on the Public Health Foundation's website following today's event. So the link to the archive will be emailed to you as soon as it's available. You can also access that archive at any time from www.phf.org/immunization. You'll also on that webpage find the slides, the written answers to the questions as promised, as well as the archives of previous immunization webinars, including the How I Recommend Flu Vaccine webinar that was held in December. On that page, you'll also find information about our next immunization webinar, which will celebrate the 25th anniversary of National Immunization Week. That webinar will be held on March 12th at 1 p.m. Eastern Time, so please mark your calendars to join us then. We'll look forward to seeing all of you. Again, please continue to type your questions in. We'll look forward to following up with those. Thank you very much. We hope you enjoy the rest of your day. Thank you.
Muted.